Good afternoon, friends. A warm welcome to each one of you to today's webinar. This webinar has been organized for two reasons. Firstly, to commemorate the Anti-Obesity Day that was on 26th of November, and secondly, to continue our efforts of creating awareness on diabetes in this Diabetes Awareness Month. The strong relationship between obesity and diabetes is very well known. In fact, any scientific session on diabetes would be incomplete if it does not address obesity. The World Health Organization, along with national and international medical and scientific societies, now recognize obesity as a chronic progressive disease resulting from multiple environmental and genetic factors. It is heartening to note that the incidence of obesity in India is more than the world's average, with over 135 million individuals suffering from obesity. The future projections are really scary. Though certain days are allotted by national and international organizations to keep reminding us about the importance of preventive measures, we all need to pledge to follow healthy lifestyle and create awareness of the same in the community on these two health problems. Scientific principles of lifestyle towards prevention and management of non-communicable diseases are very well defined. However, communicating the same to the affected and enabling them to adhere to the appropriate strategies is very difficult. Hence, it's very important for the nutritionists to frequently update themselves on the appropriate counseling strategies, as well as the strategies to improve adherence to the lifestyle advice. Friends, we have today with us an eminent speaker and expert diabetes educator, Mrs. Sonal Modi, to share her valuable expertise on this aspect. I now welcome Dr. Veena Yardi, the Treasurer of Nutrition Society of India Mumbai chapter, to welcome and introduce our speaker and also to moderate the session. Dr. Yardi, over to you.
Thank you, Dr. Subhadra, for all these kind words. It's a good afternoon to one and all. It's my pleasure to introduce one of the leading nutritionists and dietitian of our country, Mrs. Sonal Modi Chandalia. May I have Chandani her CV, please? CV slide. Yes. Can you put it on slideshow? Yes. Mrs. Sonal is a registered dietitian and also a certified diabetes educator. Currently, she's working as Chief Nutritionist at the Diabetes Endocrine Nutrition Management and Research Center, which is very popularly known by its short form, Denmark, Mumbai. And she's involved, as part of that, she's involved in various activities, to name a few: nutrition management of normal, therapeutic and special situations, development of patient education program, ongoing patient education. She's also involved in many nutrition research projects as an independent nutrition and diet consultant. She's a guest faculty at Nirmala Niketan as well as at SMBG University. She has varied experience in this field for last many years. She regularly is invited as resource person at various national and international conferences on several topics. In 2008, she had conceptualized and organized and conducted an exhibition at Nehru Science Center as public awareness and education for lay people on the various aspects of diabetes, its management and prevention, and that was attended by more than 10,000 people. She's involved in coordinating, especially from since 2009 onwards, she's involved in coordinating and teaching the US-based HOPE course, training healthcare professionals as certified diabetes educators in Mumbai. She has several publications to her credit in national and international journals. I'll be just mentioning few of the topics of her publications, so that will give you an idea about expertise that she has in all this very important related field. glycemic and lipemic response to various regional meals and South Indian snacks, fat replacers and fat blockers, newer approaches to nutrition management, dietary fats turn of events, artificial sweeteners, boon or bane, weight gain in type 2 diabetes, type 2 diabetics with different treatment modalities, metabolic syndrome and related disorders, low carbohydrate, high carbohydrate, what is right. She has also has one book to her credit, very well-known book, and she has co-authored it with none other than a renowned diabetologist of our country, and also endocrinologist of international repute, Dr. H.B. Chandalia, who's also her father. And the name of the book is Conquest of Diabetes by Diet and Exercise. And this has been written in English and Hindi. And I think, I have this copy and it's an excellent book and everything is explained very well. And I remember that time when it was released some 17 years back, it was really, very, very popular, especially the Hindi version. And many copies, I think 3 or 4 editions of same book have come. And then in that, a very interesting thing is some recipes are also given. Then another one very important book, the textbook of diabetes mellitus in RSSDI. RSSDI is the Research Society for Study of Diabetes in India. In that, she has written a very important chapter on nutrition management in special situations. She regularly has written and keeps writing newspaper articles in Indian Express under the very popular column Body and Mind, Body Talk, and also in other newspaper under the health columns. She has several achievements to her credit. And Sonal has always been a meritorious student. And, she has a number of academic awards, right from school age and various subjects, various languages, then even in junior college and graduation level. She has received prize for standing first at MSc in Foods, Nutrition and Dietetics, which she had done from Nirmala Niketan. She received prizes for several this is something interesting when I was going through her CV. She received prizes for several art and color competitions and contests at local, national and international level. So, I mean, she's a very gifted person. I think even scientific, she's a scientist as well as she's also an artist. So, very nice. So, Sonal, it's really nice to have you here. And I, on behalf of NSI Mumbai chapter, I warmly welcome you and all the participants who are present. And today Sonal is going to talk to us on very interesting topic, and that's a role of diet and lifestyle counseling in diabetes, breaking barriers to achieve adherence. So, it will be more about how to adhere to all this. And she's going to reveal many secrets today. And so please, request Sonal Modi now to please take over the session and begin. Thank you very much.
Thank you so much, Yardi ma'am and Subhadra ma'am and the NSI team. It's a pleasure to be here, and I always look forward to such occasions and events where there can be sharing of knowledge and such a lovely platform. So thank you again. Yes, may I start, ma'am?
Yes.
Yes, you can start.
Yeah.
Just before you start, let me announce that whatever questions are there, if they come to your mind, participants' mind, please write down in the chat box. All the questions will be answered later. Even from our YouTube viewers as well as from Zoom, all the questions will be taken after the end of the session, which is going to be for an hour or so. Thank you. Yes, over to you, Sonal.
Yeah, thank you so much, ma'am. Okay, so we are going to discuss today. I would just like to share, the role of diet and lifestyle counseling in diabetes, because one of the main barriers that we do face is really getting some of this across to patients or them being able to adhere it. So what we need to really understand is how do we break these barriers so that we achieve a greater adherence to diet, to lifestyle, which the patients need to follow on a regular basis. To give me a second.
Any problems, Sonal?
Yeah, it's not moving to the next slide. Just give me a second, ma'am.
Yeah.
Okay, I got it. Okay. So one minute, please. So what we have here is we start with understanding what are the concepts. The concept that we really need to understand is on basis of the intervention that is given. So in practice, when we really see, there are certain things that we need to look into, like the intervention when we are giving, what are we really looking at, what kind of concept. We're looking at the earlier concept, what was known as compliance, but compliance is really a very restricted or a submissive or a passive role of the patient, because it is the interaction between, let's say, the dietitian or the diabetes educator with the particular patient. So when we say think of compliance, we're talking more of a patient following a very playing a very submissive role and just following instructions. I'm alluding to all these because I want us to understand how we move, how we have moved historically from calling it compliance to then, moving into a newer concept, which is called adherence. So today, the words that we use are basically adherence. Now, adherence is a very independent, it's a very intelligent, active role that the patient is playing in their own treatment, in how we are putting it across and how they happen to receive it, accept it, and then are able to follow it or adhere to it. So our mainstay for the talk is to understand how we can break the barriers which do not allow adherence and how to overcome those. Another newer concept after adherence, which has come in recently, is called concordance. Concordance is really what lies in the hands of the educator or the dietitian who's administering who's doing the counseling, because they need to have a deep knowledge of certain questions as well as certain situations which the patients are going through, and provide it to be a little bit of a stress-free environment, because that will only improve the adherence. So the concordance is more developing a deeper link or a deeper interaction with the patient themselves, which ultimately the adherence and the concordance both are supposed to hence bring about what we want is the behavioral change. So the cornerstone of doing this entire process of doing the diet, lifestyle counseling, trying to improve the adherence, is to essentially bring out the behavioral change, which is brought about by being empathetic or providing empathy to people when we are doing the diet counseling. The technical matter is one part of it, but really providing the empathy and to be able to identify and understand what they're going through brings about that positive change of helping the patient to help themselves to then probably improve the adherence. Once we have achieved this at different levels, we need to understand that what are we really trying to get to here when we are trying to improve adherence. We're trying to see what is the behavior change that we get and how effective that behavior change has been. So this is conceptually what you need to keep in mind when we go later into what really is the diet and lifestyle counseling tips which would help improve adherence. So we always have the short and long term targets, where there are small step approach that is always used, because finally it is known, enough studies to show that when you get some adherence in the initial phase of the treatment itself from the patient, it's going to be far more successful in the long term. So that is why the key is to not only get short, but even the long-term adherence that we need, where a lot of these concepts, as we can see, would these things that we would be putting into effect with the self-monitoring, a follow-up, food choices. You're basically doing all these different maneuvers to improve adherence, which will go into details as we go along. But we are trying to empower the patient, identify the barriers, build their skills, all with the team support, whether the team support is from the health care professional team, or it could be even the patients of similar type, like type 1s in a group getting together and helping each other along with the healthcare professional team. All these help towards creating the behavior change for short and long term. The final goal would be to achieve an optimum glycemic and lipid control, so much better. And the HbA1cs, the sugars, the lipid controls, the entire lipid profile. So some of it is the main purpose finally medically is towards achieving those two. there is enough evidence, I'm just going to quickly go through this, that there is enough evidence proving this through the DPP study or the Ducking study, which, all showed that some of these maneuvers that were done, with self-monitoring, the physical activity, lifestyle activities, it did achieve results, whether it was weight loss in type 2 or just, seeing whether the incidence of diabetes is reduces through the IGTT study. So some of these have given us insight. This evidence has given us insight that these maneuvers and these lifestyle counseling and diet maneuvers, which work well, which improve adherence, are giving us the results of getting that 7 to 10% target weight loss, or reducing the incidence of diabetes in obese people. So automatically we are also getting much better. We're able to reduce the incidence of diabetes, or we are able to also get much better glycemic control overall if a person is prone to diabetes, even if they're overweight. So because, as my ma'am mentioned earlier, that even the obesity and diabetes all go hand in hand. So it is something that we need to always keep in mind when we are planning, which we'll come to. But the overall outcome that we're looking at for the patient, because mind you, the whole topic being that we're trying to break down those barriers which will improve adherence. What is the outcome? They are not only parameters which are biochemical parameters, but what we are trying to achieve with the person, with the patient, which is a interaction, is to bring about an empowerment. That means they acquire skills, they have greater power to manage their diabetes. So your entire process is patient centric when you plan and when you do the entire process of counseling. The healthcare professional here is not the dictator, but is the facilitator now. So years ago, it may have been very different, but with the modern times, with patients being far more educated, being far more aware of diabetes, or through healthcare teams getting more aware today, the healthcare professional turns out to be a facilitator for the same process. They learn to then do self-management, which gives a positive effect to help manage their own disease. They get a sense of responsibility and far more confident to manage their own selves. And it is essentially is for long-term benefit or to sustain. So the long-term management of diabetes, therefore, is the key is through the patient and healthcare professional interaction, which is where the entire crux of the entire concept lies, that if it is done well, then the patients are far more confident and they're able to sustain, because it is seen that if you're able to overcome the barriers, bring about adherence, even for an average of about 3 years, you're actually won you won the war, because then the rest of the life, the patients will continue to follow, because then now it's become a good habit. They have changed their lifestyle, they've changed their behavior, the behavior modification has been brought about effectively, and that is where you have a successful outcome. So I would like to, break up the lecture into 2 parts, where you have basically what are the factors which affect the adherence, because we want to break the barriers and we want to improve adherence. One could be an internal factor, which is mainly the prescription of the prescription that we give of diet counseling or lifestyle counseling. The second part is the implementation of the diet or the lifestyle counseling that is given. Is it really getting implemented? How do we break down barriers to improve adherence, to bring about implementation? So one is more inherent in the diet itself, and the other is where the other factors all around it, which may be dependent on the healthcare team, which is also dependent on the patient themselves and the environment. How do we improve that and bring about better implementation? And then we'll summarize it. So let's start with the first point, which is part of diet prescription. Now, in reality, and when we are actually in practice, we see it very differently than what we see it in the textbook sometimes, where a lot of things may not get covered. It's through experience, it's through knowing the situation, whether you're in India, whether you're abroad, whether you're in whichever country one may be in, but considering the Indian scenario mainly, ours is a very multicultural, scenario, where we need to take into consideration, you cannot have one straight-jacketed formula for any patient. So that's the first thing to keep in mind, that there is absolutely an individualized diet plan and lifestyle counseling that has to be given to improve adherence, because our goal is how are we going to get this adherence to improve. So one of the first factors in that is a diet recall. Now, see, part of for most dietitians, part of the training, you are trained on the diet recall. But I found that over a period of time, through interacting with patients, through seeing the diabetes, the obesity, the cardiovascular situation, hypertension, etc., all risk factors, comorbid conditions, you need a far more detailing recall. In fact, more than half the battle is won if you have a good diet recall, because you really understood the patient, you really understood where they come from, you are listening to them, you are understanding what their lifestyle already is like, and then from there you know how to help them make the change. So firstly, it's very important to take, I'll quickly list them, but I'll discuss few detailed points in each, is that there has to be kind of a 3-day weekday diet. So many times when the patient comes to us, we are still telling them that, if they've taken an appointment prior, that, if you can, would you note down in a diary roughly what you've eaten in the in any 3 weekdays, and also what physical activity that you do. They can make a, physical note of it, or when we take the recall orally, we are noting it. We also need their weekend diet and physical activity, because a weekdays and weekends can be completely opposite. And that needs to be understood, because when you're with your family on a weekend, or you're doing some outdoor sports or whatever may be the case, this also needs to be taken into consideration. And sometimes you find that the normal weekday diet which they're following through their work, etc., to gain adherence, you need to also take into account the weekend where they would like some leeway or would like some choices. And that is why that is very important to take into the recall for you to be able to make a better prescription to improve adherence. We also need to consider if the patients have any kind of hunger pangs where they're not able to control, and there is uncontrolled eating because they don't reach satiety, they're constantly hungry. Sometimes their blood sugars are not in control, so they're hungry. So we need to ask these questions in a recall so that we can get better adherence, because if they're going to have hunger pangs, they start binging, or their food cravings, it's not going to defeat the purpose of the diet prescription that you've given, and obviously that will reduce the adherence. Two more very important aspects also are intolerance and allergies, if they have any, because you need to know that and always prescribe accordingly if there's any kind of allergy, and their likes and dislikes. If the likes and dislikes are not taken into consideration, believe me, it's going to be impossible to get a patient to adhere to any kind of diet plan that you give. It may be the fanciest plan, it may be the perfect plan, but is it perfect for that patient is what you need to see. Does it really serve the purpose for that individual? Have you really looked into things to help do that and help adherence? So the likes and dislikes of an individual are important. Today they are, even if you're treating patients who are from a slightly middle to higher income group, or even slightly lower income group, may not have many choices, but those, when you can give them a choice, they should be included. Their likes and dislikes should be understood. The availability of food is very important. It depends which part of India somebody is from, or which part of the country. It's not necessary that if you prescribe a diet in one part of the country, that exact foods will be available in another part of the country. So I think the local food variety, the availability is one that we need to consider, besides what their usual pattern of eating is, or what their food choices are, usually their likes and dislikes. And what they're usually eating is what you need to put down in a recall for you as a healthcare professional, as a dietitian, to reflect when you're planning the diet. That is your benchmark, that is your guideline. The patient tells you far more than we realize. We have to be good listeners firstly, and let them speak out, let them say everything they want to, because it's from there that you get many of the answers itself. So you need to listen carefully and make and jot down and understand that, okay, these are all the things that we put into consideration for them to be able to adhere to whatever diet is prescribed far better. See, other habits also, if there's alcohol abuse, there is tobacco consumption, smoking, need to be taken into consideration, and they have to be worked on. Remember, today, we are also, even if you're not only dietitians, many of us have moved into the arena of also being diabetes educators, because it's not complete sometimes only being a dietitian, when prescribing diets in diabetes, obesity, etc. We need to also know what goes around it, what is in the environment of the patient, what are their habits, if there are any habits that need to be broken, so that it improves adherence to the diet itself, because some of these will not, otherwise they will come in the way of adherence. So once you know them, you have to address them with help of the medical professional. then the standard measure of food that is being used. So everybody in our country, see, we have different thali sizes, we have different plate sizes, we have different vati sizes. I mean, it varies. When a patient comes to me and says, okay, I eat a bowl of this, I have to ask them, can you please explain to me what is the size of the bowl, or send me, or bring it to you. When we were doing, patients were coming physically for consults, we realized that we asked them to bring it with them. So I know that roughly this is the size, because our chapatis also are from a size 15-gram chapati to 100-gram paratha. So we need to understand what is the standard measure that they're using in terms of the quantity of food they're consuming, what kind of that serving size they have at home, which you will then fit into the diet plan where we have standard sizes, and accordingly it will improve adherence. Otherwise, you would be saying have 1 vati, and that 1 vati is really 2 vatis as far as the patient is concerned, because their vatis are much larger. That would not help, and that's why that could hinder the adherence. So to improve adherence, you need to be on the same plane as to what is the standard serving size they're using at home. Another very important, one or two important of the lifestyle of the patient is their sleep timing. See, with COVID happening, with this situation of the pandemic, and even before that, there are people in the cities, in the mega cities, or in the second tier, third tier cities, the kind of work schedules they keep, their sleep timings may be haywire. So a discipline on the sleep timing and setting some pattern also is very important to understand. So we need to know their sleep timings when we are taking a recall. Their underlying medical condition, if they have any, has to be noted by a paramedic, a dietitian, or a diabetes educator, so that you know that you plan it better and you get better adherence, because otherwise you may be missing out points, and they obviously cannot do it, but they don't tell you that, you go through medical records carefully. And if they're taking alongside any other Ayurvedic or any preparations, because you want to see whether the adherence improves or doesn't improve because of that, because many times an Ayurvedic preparation is on and they do not take the allopathic, and then we don't know what's happening with the diet, and everything is haywire. So some of these are newer issues which we have learned to tackle today. I'm going to just quickly go through, because I'm not here to give you a, what a diabetic plan diet looks like, but I just want to bring about how do we improve the adherence if inherently the diet is planned properly. We have to consider that overall there have been waves of different kinds of percentages of carbohydrate, protein, fat that have been used through the decades. But overall, we have come to a common conclusion in our last 30, 40 years of experience with all levels of planning the base level diabetic diet, that overall we need to include carbohydrates to a certain percentage, which is not extremely high. We don't go all the way up to 65. We get better adherence, because when we keep the fat at about 30% with the right kind and quality of fat, between being many monounsaturated, the satiety level is much better. They feel far more satiated, and hence they are able to follow and adhere to the diet much better. They are not hungry all the time. Then we make sure omega-3 is there, because we have to worry about different things. So the adherence is better, because overall they're getting the right nutrition, so they feel healthy. So they adhere to your diet because they see the results, they see the outcome of what you've done. In protein, it's very hard to usually get even a required amount, especially in vegetarians, but we have overall a period of time seen that those individuals, we get much better adherence if they're already consuming certain their cereals through being chapatis, etc., being millets, or the jawar, bajra, ragi, etc., or it can be jaw, even if it's not wheat. If there are people used to taking that, we stick close to what their current diet choices are, and when you continue those and include those, you get far better adherence, because they're used to that kind of food. And those millets actually help adherence, because they get much better. It is known even in literature, you get much better glycemic control through having millets, because any cereal pulse combinations gives you a better glycemic control. So some of these maneuvers help. Overall, if you give any diet which has a composition which is very imbalanced, where you have to have it balanced, the adherence is very poor when you give imbalanced diets, or you give any fat diets. So I would not recommend any of those. If you need to improve adherence, you need to see that the protein, carbohydrate, protein, fat content automatically is balanced through all the meals in the day. The diet is obviously something which is not, which is high fiber, so they don't face problems of constipation with any kind of fat diet, so that the adherence reduces. And overall, remember that there is always a reasonable margin of safety with diet. With diet, inherently, you can take some of those leeways. They can take those leeways. You can provide those leeways, which improves adherence, and you can give them better choices and give some of those leeways, because they can be tackled through exercise, can be tackled through other lifestyles. So all this together, this kind of thought process improves the adherence a lot. Also remember that the adherence is not great if you find that you're only addressing their diabetes. They say, what about the rest of my medical conditions? So we have to be sensitive. The empathy of the counseling has to be there, that we're seeing the patient in totality as a human being. They have diabetes, they may have hyperlipidemia, they may have the kidney problems, they may have hypertension. We need to plan it in totality. So I'll be coming to that to just give you an understanding of that. Apart from the inherent prescription, you also need to understand in diabetes, whether it is type 1 or type 2, both which I will be dwelling on, is that the meal pattern and timing. Classically, we may give 3 main meals, 3 small snacks. So their frequency, does it work for them? Is it according to their work schedule? Is it according to their exercise pattern? Are we synchronizing it with their exercise pattern? Because they may be running low just before the exercise. And if you've not provided a snack, the adherence is going to reduce either to exercise, or they will eat more because they feel, no, I'm running low when I exercise and it's not been provided for. So they will kind of still eat, because they will disregard the diet and they will continue to eat. So overall, it is a much better and positive strategy for the healthcare professional to take all this into consideration, plan it in advance for the patient, taking all the problems into account, and therefore you will get the maximum adherence with that. So when you do, portion control also has to be taken into consideration, that had they understood what is the portion size, so that they don't binge, but they're eating through the day. Is there a bedtime snack which you have provided or not? Because your adherence will reduce the minute they face a lot of 3 a.m. hypoglycemia, whether it's a type 1 or type 2, and mainly, more importantly, in type 1. So the nocturnal hypoglycemia is scary for patients, and hence they will tend to binge in the night, if you've not provided a bedtime snack post dinner. So it's better that you provide it. That's how you design and you plan then the meal pattern and the timing of the meals that they have and the snacks that they have. They should overall, you encourage them to keep a consistent timing. They also fall into that pattern then of that discipline, and also of the timings and some kind of this thing. When they keep the consistent timing, they find that their sugar controls are better, and therefore they are happier to follow it, because otherwise lack of timing, the timings being all over the place, actually doesn't help their glycemic control, and they feel pretty unwell over after a while. So all these things have to be synchronized and understood, the meal pattern and timing, to get greater adherence through these different ways. Now, what about in the diet prescription, besides, giving a single standard printed diet, and then we say, okay, this is what you have to follow. Now, remember, the patients are coming to you once. They may come to you twice. Depends on your follow-up method. I'll be dealing with that also, but depends on how frequently you are able to follow them up or not. Remember that the diet is not forever. It's a single time prescription. You have to have a cutoff that, okay, this is fine, but you will need review. So we'll come to that point later. But then when you are giving them that diet for that one time, are you really covering all their food options and variety that they are exposed to? If they have a city lifestyle, if they have a more rural lifestyle, if they have a more traditional food habit lifestyle, are we covering these food options? Are we making sure all these are included? Because the adherence will only improve, like I mentioned, or you'll get maximum adherence when you're sticking to the foods that they are able to, which are available, which they can get. Obviously, you're teaching them to ensure that they are healthy versions of it. So whether it's a traditional foods, whether you're exposing them to what are the different options in packaged foods, the this becomes very important when they are trying. Many people are very, they would like to kind of you make some of the eating out foods even at home, but then you need to help them to improve adherence, so that they will follow the diet plan that you give, or the lifestyle counseling, in a way that is that you want to replace those ingredients, the unhealthy ingredients, with healthier versions. So let's say, for example, in a baked dish, they will use regular milk, but you know that there is a weight issue in a diabetic. So you would like them to use skim milk, or you can tell them for the white sauce, or you tell them that, also don't use maida. We don't want any refined flours. So we tell them, please use a whole wheat atta or a whole wheat flour. You can make your white sauce out of that. And there is, honestly, it tastes the same. And most people are very happy when you provide them this, and their adherence to the diet improves tremendously. You teach them how to read food labels, because they don't know what kind of foods to pick up when they step out, whether it's from a kirana store or whether it's from a fancy, from a supermarket. They need to know how to read that or share it with you, so you can give them the support system and help them understand how how to read the labels, and not land up with hidden sugars and fats, because then their adherence decreases because they don't see the results. Then bakery products, we want them to use no refined flour, so they have to be educated on that. In the food options and variety, we have to give it to them with the due caution, with the understanding, with educating them. That really helps the adherence levels. And even sweets, Indian, Western, if they want to make a kheer at home, it's possible to make it at home with a skim milk, with everything, with it being very healthy. So once they see a different side of how to cook the food, what are the ingredients to be used, what are the possibilities, the adherence improves tremendously, and we've seen this actually change and happen. Even the cooking method, they do not need to go the classic way of cooking where they're using a lot of oil. Sometimes the food is being cooked for the entire family, so it's difficult for them to cook separate. But when you are counseling the basic diet prescription and counseling methods, we need to make them understand that this diet, or this particular diet for diabetes, is not such a special diet which is because they are so sick or they're unwell, but this is a kind of a lifestyle change which helps even the entire family. So when you put that point across, they're more than happy, because that improves adherence not only of themselves, but the entire family, because they learn a better and newer way, which makes the entire family healthier. So some of these methods are what you introduce to them, where they can do it with minimum oil, where, you're giving them, okay, you've allowed so much oil in a day, this is how you can use it. It improves their adherence to know where they can use it and how they can use it and where they can put it on the top, how much goes in the cooking, how they can do a quick cooking, which will help, which doesn't need a lot of oil. Another important aspect is eating out, because with restaurant dining, which is luckily not on in the COVID, I would say that it has been, the pandemic has been a boon, because most people have been, making food at home, and they've been improvising, they've been reinventing themselves. And I think it's actually a wonderful experience and a positive experience as an outcome from the pandemic, where individuals are sharing with the family and they're cooking together and they're finding their healthy options. In fact, many of them we have seen in the whole cohort of patients that we're treating right through the pandemic, that whether diabetics and with obesity and with other comorbid or complications, their health profile has improved. There has been weight loss. They are far more disciplined, because now they have time to take care of themselves. And also the entire physical activity, if there's no staff at home doing the work hands-on, has actually improved their physical activity and their activity at home, and they're able to keep pretty healthy. So when things get better and the dining out starts again, yes, educating them on different cuisines is very important. When they only understand how to choose when they eat out is when they are confident, and they will be able to adhere to your diet better, or they land up eating out, which is unhealthy, which defeats the purpose of the glycemic control that we are trying to achieve, and it reduces their adherence to the entire process, because usually the eating out is the one which has been the one which causes the maximum problem. So that has to be dealt with also. Another important aspect, whether it's a type 1 or type 2 diabetic, just to bring to your notice that everything that I'm discussing is right as applicable for the type 1 and the type 2 diabetic. And I will go a little bit in the nitty gritty of each, which is highlighting a little bit more detailed points on each of the conditions. But alcohol, there are people the youngsters who are type 1. There are, there are even type 2 who are not very old. We have seen that, the incidence has been happening even at younger age. You find that they need to have their snacks, they need to socialize, they need to step out, they need to meet people. So we cannot completely stop it, because your adherence to any diet that you prescribe or the lifestyle that you talk about is not going to work if you do not incorporate some of their basic lifestyle, the way they want to live their lives, into it. So I just put it out here for you to understand that when you're guiding them, you need to guide them on the amount, the quantity, the type of alcohol, how they can have it, when they can have it, what kind of snacks that go with it, because some of these cause severe hypoglycemia otherwise at that minute, especially in a type 1. It can never be empty stomach. So we need to know the kind of snacks so that they can adhere better. So they will go and they will choose options, even in a party, or even if they're socializing or anywhere out, they can order accordingly, or in a party, they will choose those like salads as accompaniments, or steamed snacks, roasted, grilled, which are completely healthy to have and can be fit into the diet plan. So that helps them to maintain their lifestyle as they would like. And so the adherence to the diet improves tremendously, even if they need sometimes carry foods because they are in between work, they're traveling. So these all scenarios will again arise once the pandemic, kind of simmers down further. So we find that they need these convenient foods with them, which usually can be a fruit, any of these things which are easy to carry, which are not perishable immediately, which can work for them on the way before they reach their workplace or they're reaching home. Or it's a type 1 who is a youngster who is doing a lot of physical activity, a sport at a serious level, or exercise. They're very active, so they need some of these as their carry foods around, and this improves adherence because you need to provide for this in the diet plan and the prescription. So this was covering overall all the inherent factors or internal factors in the diet itself. But now let's move to the external factors, which are also equally important. One basic baseline that you should assess to improve adherence is, do they have enough diabetes knowledge, which is really the function of the entire team, the diabetes care team, which is dealing with them, the physiotherapist, the dietitian, etc. Or you're just a diabetes educator who's an all-rounder. Then you need to understand that, do they have enough knowledge on all these aspects stated here? Then they are able to handle their disease better because their understanding is better, so they're able to conform to the diet plan and to the lifestyle intervention that you give far better. So the adherence improves. We have been following for the last 40 years a very practical method, which is exactly the 70 calorie exchange. I just wanted to bring this out because there are some very positive points. This is what is followed by the ADA. Essentially, it is dealing with cooked foods, which is why we have found that the adherence is superb. If I start last 30 years, I'm noting that if I'm telling patients that they have to take raw weights and they have to measure and then they have to cook, it's almost they are not able to follow, they cannot adhere, and they give up after a while. So to get any short-term and then long-term adherence and to improve it, having them as cooked food measures in terms of the measure size, that whether it's a vati or a cup or a glass, depending on what you convey to them as standard size, which is all stated and stipulated in the diet plan when you give, it really helps for them to know that they have to just take 1 vati of the khichdi, 1 vati of oats, or they have to take a chapati, which is 30 grams after being cooked. So they are very easily able to weigh that once on a kitchen scale and then not have to worry and weigh all the time. You also have to know that the 70 calorie exchange provides a huge flexibility within the exchange, which is up to us as healthcare professionals to help them improve adherence. You provide them flexibility within the exchange, within the cereals, within the pulses, within, like, for example, if it is a reasonably well-controlled diabetic or a person who is fond of sometimes wanting to make a single meal, I tell them, okay, if you're going to have 2 medium-sized potatoes, then I would like you to skip a chapati today, which is their 30-gram chapati. So it gives them a flexibility within the exchange of a cereal exchange. These are just some starchy food exchanges which do exist, but we make it an absolute no-no. But sometimes an adherence improves because when they go out and eat, sometimes they're eating a potato dish, but they should know how to exchange to improve the adherence, and they can stick to the plan. You introduce them to the vegetable groups, fruit groups, the lesser sweet fruits, the sweeter fruits. So these are all part and planning of the diet. But the point is that the healthcare professional has to convey all this in detail, has to interact with the patient, give it in the plan, explain to them. Then they know that if I can't have this fruit, I can have this much of this or this. If this is not available, this is what I can have. They need to know and get empowered to understand how they can exchange it themselves. So essentially what we always stick to is giving them and always implementing, which is the main part, is the implementation of the diet or the lifestyle counseling, is give them a menu style plan. I'm just running through this for you to see what it is like and what we really use, because these are implementation is what is helping. This is like a typical 70 calorie exchange, so it's easy for us to calculate. I'm flashing these slides only for you to understand that how we really, I actually plan the the diets and share the menu style with them accordingly, which is just a glimpse of that. Whether it's diabetes, we have the associated conditions of hypertension, there may be many other conditions, so we are very well stating, we are giving them options for the different meals. Through this, you will notice that everywhere it's a balanced diet, right through from morning to night. It's a balanced diet with the timings you have stated, with all each breakup given on how they can have it and how they can exchange it. And you can see even the measure is given here. So it's very easy for them to know, okay, I'm talking about a glass. Am I saying half a glass? A teaspoon is 5 ml. A chapati, we are taking a standard 30 gram. It's a fulka, 15 gram, you can have 2. All these improve adherence when you explain to them, you dialogue with them, and you're giving them the options. And you're talking about the food groups also. We also give to improve adherence. Remember, they need to know how much fat to take. Otherwise, they get really confused that where am I supposed to use it? Where do I put it? It's all a matter of execution of the plan and the implementation to improve the adherence. So we state that we break it up and we state it to them where they could have, see, not every patient is going to have an olive oil and a canola oil, etc. We have enough population where we need to even deal with the low income groups. So we need to make sure that they can even have their local oils. You cannot tell somebody in the south who's having coconut oil, no, you need to completely stop that. Let's stick to more or less what kind of oil they are locally managing to eat, unless they're in the cities and they have the facility to, and they are able to, with their money power, make those changes to very fancy changes, but not needed every time. You can even have the basic groundnut oil, there can be mustard oil. So a lot of it we have to adapt. We as healthcare professionals have to adapt, understand the local cuisines to improve adherence for the patient. These are just simple to tell you that even a salt restriction is given, it's a hypertensive. Now, if you just orally and verbally explain to them, it's not enough. We need to put it across so they understand exactly which foods to include or not, the do's and don'ts, what is your diet plan, what is your exercise plan, everything is stated. I'll be coming to exercise, but as a lifestyle counseling, but everything is stated to the T so that they understand that this is what I need to take. This is after due dialogue and them understanding everything, that they're then able to adhere it to far better. I'll just run through this. This is like a diabetes and even CKD. So you need to consider there, here you'll consider a potassium restriction, but it's given separately. It's not just stated in the menu plan that you write that, okay, eat these fruits only or these vegetables only, and then they're left with no other options. And then they'll phone you and ask you, but I'm having spinach, I'm having this vegetable for last 5 days. Are there any more options? So we provide those options. It's inbuilt so that the implementation is easier. They can look for those options when they go out, and hence they're able to adhere to the diet better. They're not stuck. So that is part of parcel of the implementation of the diet on the basis of how the menu style planning is done. Another very important aspect of the diet implementation to make it more effective for adherence is that the diet counseling method. Now remember that we discussed the first part, that how the diet counseling should be, but a very important aspect is in the direct counseling method done by the dietitian is that please directly counsel the patient. If you want improved adherence, do not let a husband tell you that, no, please, my wife will call you up. You can explain everything to her because she makes the food at home. I'm sorry. We need to directly counsel the patient. They need to understand what is needed, what is good for them. It improves the adherence tremendously because they are able to then comprehend why we are explaining what are the precautions to be taken, what are the foods to be eaten. Tomorrow they're stuck somewhere. They're not going to phone up their wife and ask, now what should I do here? You have to directly counsel the patient. We in fact refuse to counsel anybody else unless it's a patient who is having any difficulty in cognizance and needs special care. The patient has to be directly counseled, male, female, even the child. It's not only counseling the parents or giving the diet thing to the parents, but it is about counseling the child directly. The language, all these improve adherence when you can dialogue in the common language. If you can strike that the languages and dialogue, the prescription has all these options written. Their dialogue is also for giving recipes, giving their options, healthy food ingredients, availability, and food label interpretations. all are discussed in your diet counseling method. It helps them, educates them better. Tomorrow they know what options to find when they leave the house, what kind of raw material to buy at home, or the ingredients, and they bring the right ones and they discuss it with you. They will share it with you. Keep an open communication, that sometimes you need to do some hand holding where they share it with you in the initial first or two times that they talk to you, so that they know that there's somebody to guide them. You also need to know that we need to understand that to improve adherence, they need to be aware of their treatment regimes, their medication. What is the insulin? Is it the type of insulin they should be aware of? Its action when it takes place? All these help, especially both in type 1 and type 2. In a type 2 long standing who needs insulin, or for a short time is undergoing a surgery needs insulin, or for a type 1 who is maybe on, even sometimes they are on the insulin pump, then that is a far more detailed, it's another separate lecture altogether if you do carb counting. But not question of carb counting, it's about them understanding. Do they understand basal? Do they understand their short acting? Do they know that, okay, when they have a high fat meal on any given day, their blood glucose levels are going to have a delayed effect? So you need to educate them on also what is the medication regime going around them, and synchronize this with the diet and lifestyle counseling that you're given. They all go hand in hand. When you educate them on this more as a diabetes educator, you're actually achieving a greater goal of adherence to the entire lifestyle changes and behavior changes. So another besides medication, there is the physical activity and exercise pattern. This, I think, is the mainstay along with diet. We have seen through studies and through research that it is always, they go hand in hand. You get a much better adherence if both are there present. We encourage that there is a margin of safety in diet. So if you want improved adherence and to improve the whole process of long-term adherence, we encourage them to be more physically active, have an exercise, whatever may be their health condition. Whether they are not able to walk so much, then we give them optional exercises. We make sure we look into the type, frequency, timing, the merits, demerits, give them all the precautions and contraindications of certain exercises, whether it's yoga, cardiovascular, etc. All that is dealt with, so that when they're taken, the diet is planned along that exercise pattern, so that when they are doing it in tandem, they actually achieve far greater adherence, because they finally have gotten overall lifestyle counseling which improves their adherence. So like, for example, if it's a type 1 who is a child, who's a youngster, a teenager, who's going into exercise from school, etc., you need to take into consideration the exercise time, duration, etc., everything. It has to be a small, reasonably intense size snack before they go in. They need to know, they need to, what they have to have after, how much hydration. So some of these things are what improve adherence. Otherwise, that child will just say, no, I'm stopping this activity, or they'll say, no, I'm just going to eat what I want. So you may find either extremes unless you deal with it and you realize that you need to help the adherence improve. Sleep and pattern, like I mentioned already, is also very important in this whole process to get improved adherence to an overall lifestyle counseling. You need to make them realize that their sleep patterns are important to fix and not be all over the place. Another very important aspect, essentially for diabetics, we are considering is self-glucose monitoring and their 3-month averages. The importance of that. In fact, we give them a regular chart where they have to maintain. We don't make them prick themselves 8 times a day. We stagger it through the week. So they learn that, okay, when I eat this food, we let them experiment with new foods. And this is something we've been doing for many years and for decades, especially with type 1, because a type 1 has usually been a youngster or a young adult, and there is a lot of variety and leeway that you need to give them in their lifestyle. So to improve adherence, we tell them, okay, you're trying having a pizza from this place, please do your reading before and after, and let's see how it goes, and we'll know how this food behaves with you. So when they experiment, they feel empowered, they feel educated, they feel like they know how they can handle new foods besides the carb counting. Hypoglycemia, they have to learn about. It's essential for both. And the food diaries that they maintain help us get better adherence. We do that. Usually, remember, we are trying to get them to meet us quite often. I will come to that frequency of follow-up, but that is also something that we need to take into consideration. Then they keep a food diary. It actually reveals a lot of things to themselves when they discuss to you that, here, I noted that I'm doing this today, which is wrong. So, maybe can I change it to this, to something else? Can I replace this food with this? So there's a lot of back and forth interaction, which helps them improve their adherence. And they come to a pretty set pattern after that. Then importance of HbA1c, yes, the glycemic control they have to understand. So this is a kind of a chart that we give them so they can maintain their blood glucose levels and then share it with us. Now I'm coming to the crux of where actually we come in a very, very big way. Besides doing all this and over and above, is keeping the communication and helping them skill build. The diet counselor has to have the rapport building. You have to give them comfort for communication where they feel free to talk to you at all levels. So when they come to you the first time, you're not just going to say, what do you eat and what do you eat? Just tell me this. No, we need to understand in totality, which comes in the, we connecting back to the recall, that you're understanding everything about them. Let them talk. Some difficulty at home, some, logistic problems, anything could be coming in their way to to not allow them to adhere to the diet better, and that is where we have to help them problem solve and resolve those for them, but guiding them, taking them into partnership to adhere to it, not just telling them that you need to do this and don't bother, just do this every time this happens. No, situations can change situations. So they need to develop skills of how to manage the food exchange, evaluate different foods, adjust their own timings and their food to their timings, how to manage in an emergency. All this improves adherence to their diet and lifestyle. If they're traveling, what to do. If they're fasting, sometimes for religious reasons, or intermittent fasting, which is very popular sometimes today, then if they're eating out, etc. All this is required, because when there is good communication, there is a two-way process. The sustenance of an importance of maintaining that long-term plan you will achieve. Otherwise, it gets very difficult if you don't get the adherence. So the follow-up counseling or the reviewing has to be emphasized. If there are few consults that they should do with you, that means they come for follow-ups, not with the doctor alone medically, but also with you as a dietitian or as a diabetes educator, because the first initial visits and 1 or 2 visits only get them accept your acceptability and the acceptability of what you're prescribing. Whether it's lifestyle, exercise in hand with the diet, or it's their medication that you're making them understand, or their lifestyle already existing, which you want them to change through these different behaviors, you need to understand that that's the only initial phase of acceptability. The regular follow-up, when you do about couple of times, they continue to follow up. We insist on being reviewed so that there is an adherence that you develop for long term. And also remember, it's not about you giving them the diet. It's also about every time they come for you for a review, you are also checking that whatever you have prescribed, whatever you have tried to make them implement, has that been effective or not? It's our self-assessment as healthcare professionals to know that we did this, did it work? You have to have a check on that also and a review of that. So we need to also make patients aware when we want to have an increased adherence, that if there's any change in pattern in their lifestyle, they must connect with us so that we know how to guide them in. Probably sometimes there is a very, very, there is some mishap in life, or there is some, they have depression, or there are any other lifestyle changes that may happen in their pattern, or some events in life, which they need to completely change their diet. They cannot just continue with the same old plan that you gave them, either for lifestyle or for diet. It needs to be reviewed and needs to be addressed when any of these issues are to be tackled, or any work schedule has changed, or any lifestyle change. So that comes to bottom line, to improve adherence. When you put all these factors together, whether they're intrinsic, whether they're to do with the prescription or the implementation, all these factors together improve their adherence. So especially in type 2, when they're lean diabetics, we see that the adherence is improved when you're giving them adequate caloric intake, they're calorie dense foods, but you need to break it up into 3 meals and 3 small snacks, which usually work the best as a dietary pattern to offer to them, which helps a lean diabetic keep better control, and there's better adherence for them, because it's impossible to give them everything at one time. Another very important group, which is really the point of discussion, is also the many diabetics who are obese, which tend to be obese. So there, a hypocaloric diet can be administered. In that hypocaloric diet, mind you, if you want to improve adherence, you need to be quite innovative. As a healthcare professional, that's that's where our creativity comes in, that in that hypocaloric diet, if you're prescribing it, which works quite well for them for long term or for even short term, and then you keep reviewing it, are you upward revise it or downward revise it according to their weight loss or fat loss, you see that are you providing the food variety, are you giving the correct low calorie foods, are you allowing them a sweetener which improves their flexibility for their sweet taste, are they also adhering to their exercise which will improve their adherence to diet, because they go in hand, because exercise is a very important component for an obese diabetic, even more so. So some of these things have to be taken into consideration. They improve adherence. When we have seen this happen, where in our own cohort of several hundred patients, we have found that many of them are able to maintain their weight loss. The sustenance of the weight loss was maintained by 90% patients. Usually it's the other way around. Long-term sustenance after 3 years, when we followed them up, they are saying that we are very happy, we are following things, we know, we are educated now with on diabetes, we're educated on the food and nutrition, the nutrition knowledge. All this is helping us to continue this plan for long term. We don't feel we are missing out on anything. That's where the adherence helps. Then the other group, which usually many times we are faltering on, or we don't know how to deal with, or they are very sensitive group, is the type 1. The type 1 need to get all these listed, all this entire list of things have to be, you have to deal with them, educate them on it to get better adherence, because they need to know if they get severe hypoglycemia, going to ketoacidosis, you're not going to get any adherence at all, because that individual is really struggling to begin with. So those should not be happening. A balance, how to have a balanced nutrition, that education has to be given to the youth or to the teenager. The behavioral education on how they are going to be able to burn all this, how the exercise goes in tandem with this. Remember, in this group, two most important things you need to remember is that they're in development and growth phase. They also have their moods. It's all very highly hormonal fluctuation. You need to make sure that the diet, to get better adherence, you're not affected in the long term their growth. So the adequate amount has to be given, but importance is to improve adherence. Give them the foods which will help their growth, otherwise you'll find stunted growth, and that itself will retard the adherence completely, because lead to other problems. So that is important. And in this group, peer pressure, you find that in type 1s who are youngsters, adolescents, adults, there's a lot of peer pressure that they want to eat what their friends are eating. Like I said, there is a reasonable margin of safety with foods, but even though you teach them to eat right, to eat healthy, you make sure they're exercising well enough, peer pressure has to be taken into consideration to get better adherence, because if you put a blanket no on things, they're definitely not going to listen to you, to the diet or the exercise. They will quit it. So whether it's their sports, whether they need to understand snacking, whether they need consume a little, some alcohol if they're youngsters, or whatever is the social setup around them, the peer pressure plays a major role. You need to, as a counselor, tackle that peer pressure along with it to really make the diet and the lifestyle counseling effective and improve adherence. Once you've dealt with some of these psychosocial issues, you actually get improved adherence. So sometimes you're spending a lot of time doing that, additional to everything else. So this overall covers for us to understand that there are many barriers, but these barriers can be many. But the important thing is how to be positive as a counselor and help them overcome, rather than telling them, sorry, I can't do anything about this, but not reprimanding them, but talking to them that, yes, this is your lifestyle. And you come to some middle path with them to understand, yes, I understand you're doing this, but this is its impact, this is its effect. So can we kind of consider this, and can you consider doing this instead? Try it out. So you put it a little bit of as a trial and error. That is why the follow-up, a regular review is very important from a counselor's point of view, to make sure your patients come for regular reviews. Their diets need to be changed, their lifestyle needs to be readjusted or needs to be modified again, or reviewed, because they may be facing different problems. So the barriers can be broken if you address these problems of whatever you're prescribing or implement, or whatever implementation of the diet and lifestyle they have to do. These intrinsic and extrinsic factors which are modifiable, you have to individualize them for each patient to really make it effective and to improve adherence. Today we know, because this is a paradigm shift, there is no longer the word compliance. Patients are going to adhere, and that's what's going to bring the long-term sustenance of through adherence, to be able to bring about that final long-term adherence and better outcomes of all the goals that we want to achieve with them. The efficacy of the adherence will therefore depend not on the patient mainly. Actually, it depends more on the rapport between the healthcare professional and the patient, and the comfort level that you can get. Because whether it is a low income group, middle income, or high income, they're all patients to us, all equal. So we need to help them with whatever their setting and their background is, and the best that they can do, and make an adjustment in that so that they can get the maximum adherence. This is what will finally help us reach the goal that we want to them to reach, of their glycemic and lipid controls, and improve with that effective improve with effective adherence. Only when the adherence is effective and the efficacy is good, will you also get better of these other controls that you will see, which will finally emerge to bring them to a good stable level of managing their disease for short term, daily basis, long term, retard certain complications, prevent micro complications, vascular, macrovascular complications for type 2, type 1 respectively. So, accordingly, it will help them in the long term to manage the diabetes. I would like to end with saying that the basic thing, the main dialogue that we need to do with patients is that you are not alone. This is not a different diet. This is a diet that I would like every normal person in the population also to follow, because you're only getting healthier with this diet. So these are options and a plan, and the lifestyle that you will follow with it is only, in fact, you're lucky that you know that you need to now do this. So you will be far healthier than a counterpart who's normal, who is not following any of this. So I believe that it's only a win-win for a diabetic patient and an obese patient to understand, and then we can take it from there and help them accordingly. So I would like to end with that, and we can take any questions, ma'am.
Oh, thank you so much, Sonal. It was a wonderful session, a very comprehensive. You have covered so many things, and you have stuck to your time of 1 hour. Exactly. But we have purposely kept a longer time after this for the question answers. Absolutely. Because, not only nutritionists and dietitians are listening, and many students are there. Absolutely. And also people living with diabetes, they are also there, many people. Correct. With diabetes. So, I'm sure, they must have been very happy, because whether you are newly diagnosed or whether you are living with diabetes for many years, you have given them a lot of hope. And then you have said that, adherence is the key, and it's not difficult, although there could be many barriers. But then how these barriers can be overcome. Okay. So you have suggested many strategies which are very practical, and, your entire session reflects your vast experience in this field, because, they are really coming from your heart. As you are talking, I could make out that, like these are all tried and tested and evidence-based, whatever suggestions that you have given. So thank you so much, because, it was wonderful session, very comprehensive. You have covered many things, and, many have appreciated your session, and they have asked if they could get the slides, your presentation. So if you feel it is right, then if you, want to send it, again to us, and then we can forward,
Yeah, I would be happy to do that, ma'am, because education and knowledge has to be shared. It is meant to, go to and reach out.
Very nice of you. And what, very nicely, you have also outlined the role of dietitian, how important it is. And, like why, like this indirectly, it was very useful, the session, even for a person with diabetes, as well as for, dietitians and nutritionists, that what points they should keep in mind. I think that was really, really excellent. So thank you once again for your brilliant session. So can we move to the question answers now? Yes. Before that, a few things, what I just want to highlight also, what you have talked, though in the summary you have said everything. Right. I mean, very nicely you have explained the concepts, certain concepts, intervention, compliance, adherence, because always, many times there is some confusion also, so very clearly you have said, and you have given right examples also. And the factors affecting adherence, I think you have not left any factor, internal and external, and for everything you have given solution. And what I like most, you have said very clearly that every person is different, and so individualized meal pattern and the to consider the likes and dislikes of the person along with all allergies and so many things. And also the holistic way, it's not only the diet alone, but how the exercise, yoga, then, sleep, then stress-free life. I think that's very, very important. And, another very important thing that I like is that the involvement of the person, who is having diabetes, even the person should be actively involved, because it's person's health, and he or she wants to improve and wants to, because, they want to live a better life, definitely. Absolutely. But it is in their hands only. Not to just, because this, even I have often seen that, tell my wife what I should eat and all that. She makes you involving, you should be aware. I think that was very nice. And even self-monitoring, what is my glucose level, what is my HbA1c, मैंने क्या खाया तो कम होता है, क्या ज़्यादा होता है. So you are your best doctor actually, by knowing all this with the right inputs from the dietitian and the doctor. So it's very well, you have covered, and then I think it's brilliantly done. And I'm sure with this, we feel now it's very easy to conquer diabetes. I mean, it's nothing, and we can easily live for several decades, live with diabetes. So it was really nice. So we will move to some questions now, and then, there are quite a few questions which are coming on our individual WhatsApp also, then on YouTube, then on Zoom, and then, so we both will be, I'll be asking some questions, and Dr. Subhadra will ask some questions. So first, of course, related to COVID, we are all in the COVID pandemic, so you can imagine. So you have said about the prescription is very important, and to adhere to that prescription. Now, when as a dietitian or nutritionist, someone wants to take a diet history or, do diet counseling, then about the portion size or whatever they're eating, now it's going on online. You are not meeting the person, you are not able to show, or they are not able to. So, how to overcome that, because you should not misjudge. And second question related to this, because you said exercise is also very, very important. Correct. So when you are, especially 60 plus and, elderly, like when you feel that exercise is must, minimum 30 minutes you should walk every day. And then, but with this COVID, there's so much of fear, and even family members say that, now you are 60 plus, don't go out. And at home level, how much exercise one can do. So what is your take on this, how to do that, do the diet counseling online, and then about the exercise?
So as rightly said by you, ma'am, the COVID has taught us a lot, an unprecedented pandemic, which has actually given us a lot of learning to humanity in general. But I would say at an individual level and family level, that the entire process of how we deal with taking the diet recall, because we've been counseling patients because they suddenly were in trouble. See, patients have been in trouble who had nothing to do with COVID. So all diabetic patients left in the lurch. So it was our duty to make sure that how do we establish. So we moved to telemedicine, which is online. And in that, even the nutrition counseling. So what we do is normally is that if something I need to see visually in the whole gamut of things, I make my notes. I may have a laptop in front of me. So I make my notes per patient, there's a recall. And once I do that, I know I've gotten all these factors so that I can plan the diet. So that is one point. But the second thing is that anything I need to see visually, whether it's a patient who needs weight loss, whether the patient is a diabetic who needs weight loss, whether it's a patient whose portion, I need to see the portion, I go onto the video call with them. And they can actually see me if they want to talk face to face, or we tell them, you just send me a photograph of what this is. Or you put how many ml of water and you tell me how much this is roughly. So from that, we can gauge visually from a video or from them sending pictures. We're working through the WhatsApp on that. We're working through email. We're working through the video call. So that gives me a visual idea and I don't go wrong on it. So, when we are planning, an overall idea can be there. We don't go drastically wrong on it in this current situation. So that is how the online works, and it's working pretty well because they are getting the help that they need and the guidance that they need at home, and they're able to make, do all those changes and modifications and keep themselves safe, and yet, do the needful and not go wrong on portion control. So that is for the first part of the question. Now, as far as exercise is concerned, yes, everybody's exercise and more or less physical activity is stopped because nobody was stepping out of the house as far as COVID was concerned. So slowly, as things have opened up, we have been telling patients that if you are unable to go down, either you don't have space down in your building or in the area, you don't want to go to the park close by because there are too many people, as it is there are less spaces in cities, but yet then in the house we have this is something we've always advocated through our book also, that Conquest of Diabetes and Exercise, that there should be always an alternative. You should always have a plan B, because it can, life changes every day, whether COVID or not COVID. Today you don't have the time to exercise, what do I do? So you do have a plan B where you do floor exercises, stretches, you can do even some cardiovascular there depending on the age. So person who's 60 can't do a walk outside but can do a stationary cycle. You do a cardiovascular equivalent exercise which you can do at home. That is for the cardiovascular equivalent. And additionally, one can also do something like, which is the resistance training, or the if it's a younger person, so a resistance training also you can inbuilt at home through little dumbbells, through little the springs, etc. Even for an elder person who needs to stay fit, you need to be supple, your flexibility has to be there. You may put in some yoga in it, because that's possible at home, but again with the due precautions, because we have to give precautions of exercises for people with retinopathy, people, because sometimes there's a bleed in the eye if they have if they're doing any exercise which has where you're holding the breath, so like some of those we tell them to avoid. So with due precaution of the contraindications, etc., this plan can also be made as a simple exercise floor plan at home.
Right.
If you cannot step out at all, which is what we all have been doing finally at home. Everybody has had to devise their own method of doing it, but with due guidance from your counselor, it can be done in a better and a structured way.
Very true. Very, very well explained. Now, another thing, with relation to this diabetes, now we keep getting lots of, messages on WhatsApp as well as on, through friends. This is better. Try this. Your blood glucose will come down, or have just 2 meals you have and it will come back. Then, you have take only keto diet. So, we sometimes, people get confused, like whom to listen. So in such a situation, because some people say so confidently, morning I have taken this and then it has helped me and my blood glucose has come, so like there is a lot of confusion, and then, there's, people are anxious. So in such case, what do you think, whom should they approach, or how they should know about it?
So I would say that if it's a diabetic, diabetes, obese, type 1, type 2, whatever may be the scenario, we're dealing mainly with that, is that you need to contact your diabetes team, that is your medical professional, your dietitian, whoever is there in that team. The reason, there are two things. Usually, whether I'll first deal with if it's a keto diet, and deal with intermittent fasting, diet. A keto diet is an absolute no for a type 1. It's an absolute no. I mean, it completely should not be done, which is blanketly outright. I would say that it's not a trial and error you should do at all, not as a professional. Okay, as a healthcare professional. When you're talking about keto diets for type 2, so sometimes it helps to some extent for short periods, but also you have to remember that it's very high fat, saturated fat. You see that the composition of that diet may defeat the purpose in the long term. What I also would like to mention here, which is related, is that we're not only doing diabetes friendly diet, we need to do heart friendly diets. We have to keep in consideration all the risk parameters and comorbid conditions. So we need to keep in the hypertension, the hyperlipidemia, everything. So if you're giving a ketogenic diet to a type 2 for a very short period, you may be able to do it in a very tight control fashion, but it's not something that would be recommended long term or for all time to come. So that is where the keto diets are concerned. For the intermittent fasting is obviously, these don't apply to type 1s. No hanky-panky, no fat diets for a type 1. There is just no other road. This is the only road, is to do it the way it is classically being done, with experimenting and taking the trouble as a health counselor, as a dietitian, to give them the options in life and in the foods and in the pattern and what they can do with it. But in a type 2, intermittent fasting sometimes can help again for short periods. Like, for example, the problem is in the definition of intermittent fasting. Most people are saying, I'm eating in the morning, then they are out to work, or now they're working from home, or whatever may be the scenario. Then they eat in the evening. So they think they fasted. So you have to understand fed state and fast state. So we are more in the fed state when you eat at 10 in the morning and then you eat again at 8 in the evening. You actually have been in a fed state longer than in a fasting state. And it should be the other way around if you're doing, so you're really not doing intermittent fasting. The terminology is being used for it. So intermittent fasting is really if you are on a 16-hour without food and you're eating in those 8 hours, where you are eating in that structured 8 hours that you have decided. So that is really intermittent fasting. So honestly, I don't think everybody is really doing intermittent fasting. They are doing this on an ad hoc basis where it is partly helping because their total food intake has reduced.
Right, right.
So when you really plan it as a counselor, then you need to take into consideration their timings, their lifestyle, everything, what is their job, what is their occupation, etc. And then give them that 8 hours. It can work for short periods and get better glycemic control and adherence in people who are pretty educated, receptive, and they are able to adhere to this.
Right.
That is
Now, there's another question about, use of artificial sweeteners.
correct.
Whether they should use and which is the best.
Okay, so artificial sweeteners is a topic I've always loved to talk about, but it's been an old topic that's always been discussed on all platforms, and it's relevant and pertinent. Is that artificial sweeteners can be used? We have enough literature and data to tell us that it is used in type 1 and type 2. Both can use artificial sweeteners, so blanketly that gives you one idea. And the especially it is great for improving adherence even in the obese type 2, because they need that option for a sweet taste, for the palatability, or to enjoy something, because we don't want diabetics to feel deprived, that they have to be deprived in life. They are all holistically it has to be handled. So the sweetener it works very well to improve adherence in obese type 2. It can be used across the board, except we take caution and we have only specific ones, which if you read literature you will see, or even our articles or in our book, is that for pregnancy or for anybody who may not tolerate, or in a phenylketonuria, etc., depending on aspartame, etc. So those conditions are different. So pregnancy we take it as a special condition where we cannot give all of it. Now when you come to that, in general overall perspective of what is a good sweetener, there are the non-nutritive sweeteners. The one which don't give calories is the ones you go for. They are called non-nutritive. Usually you have either the aspartame in it. I'm talking generic names, not brand names. That you have aspartame or you have sucralose. Either can be fine. Some people find a little bitter aftertaste with stevia, which is a natural one. These other ones are synthetically manufactured, aspartame and sucralose. So this, if you're taking stevia, if one doesn't feel the bitter aftertaste, one can also have that. So these are roughly the three that you can stick to. The quantity that we normally have, the sweetness consumed is not really bad. It's not really harmful. Only in special cases you need to consider before you administer it as a counselor. And also if any child or youngster or adolescence is just like abroad, that happens more, where they're drinking colas instead of water, then we need to know that, okay, diet drinks are not the best recommendation.
Yeah, there's one question about meal replacers. These days people do take. So what is your take on that?
Yes. So meal replacers, I am honestly, as a professional over the having practice of the last 30, 40 years, we are not very gung-ho on the meal replacers. I would rather have them make a composite meal from easier ingredients and then give it to them.
Hello?
I think there is some
I-
Wi-Fi
problem.
problem. She'll come back.
Yeah, she'll come back. Yeah, yeah. Yes,
We'll just wait for a moment.
yeah, we'll just wait.
Yeah, she has some. Sonal, you can join back.
Now, can you hear?
Okay.
Yes.
She's back.
Yeah. Sorry about
No,
that.
no, no.
So we were talking about that, no? Artificial
So meal replacers is
meal replacers, correct.
essentially, I am not very much for them. They could work in special situations, or there's a special need for it at that short period, at that time, some logistic problem, something on those lines, but not really overall. Not really overall. I would still work with what we have and the foods that are available and work with them.
Yeah, now before I hand over to Subhadra for another set of questions, let me tell you once again, like there's a lot of appreciation that is pouring in, and
Thank you, ma'am.
they have really liked your slides and the content of the slides, and they're repeatedly asking for the slides.
Sure, I'll share it.
What do you feel? How important is the psychological support for
Yes.
adherence to
Correct.
this whatever prescription?
Yes, yes. So it's some external factors. So like I mentioned earlier, which sometimes is a whole. When we're doing the counseling, we are really not only doing the diet. Even as educators, we're not only doing medication, exercise, SMBG, this, that, and diet alone. There is a lot of psychological counseling. So first, there has to be in the recall part, not only a diet recall, but an overall understanding of where the person comes from, what makes their life the way it is, understanding what are their difficulties and the barriers which may be existing at home, at work place, or even for themselves psychologically, which they are not able to overcome. So sometimes there is a lot of psychosocial counseling that we'll end up doing along with the diet counseling for an overall adherence improvement, or an improvement to get better results. Because when you tackle those, more than half the battle is won to tackle the rest, which has to be just implemented and executed as foods or as exercise. So what are the limiting factors? We try and understand first, whether it's a youngster, is it the peer pressure bothering them, is it because they don't feel good the way they look, so self-image. There are a lot of psychosocial issues which happen with type 1s. There are others which happen with type 2. Depends on the age, depends on their social status, depends on the pressures around of the environment or home or family. So a lot of that. Sometimes it is, earlier it used to be a lot, which I think as a not a taboo anymore, is how do I take insulin at the workplace. Those used to be, a lot of those things used to be as barriers. So when we talk to them and we explain to them to be transparent, be open about it, to discuss it, we discuss with them and we try and see how we can problem solve, where any other additional family health giver or member, it needs to be involved to help resolve this. There could be many psychosocial issues, but they need to be addressed, otherwise adherence is poor.
Yes, thank you so much. Now over to you, Dr. Subhadra, for for another questions.
Yes,
Thank
sure.
you so much, Veena. Actually, it's very true, Sonal, and thank you for your wonderful session once again. And it's very true, what you were saying is very true, because the children who are suffering from type 1, or maybe adults who are diagnosed with type 2,
Right.
first thing is it is always a shock for them to be diagnosed with some condition, and then always keep feeling that they are different from others.
Right.
Okay, so that itself probably to some extent puts them off, and maybe their overall physical work capacity, especially for children, I have seen that they feel very deprived of so many conditions of life. But however, the psychosocial aspect plays a very important role in adherence, and giving them motivation and hope in life, that's very important. And mostly the dietitians are doing it, not only the counselors,
Absolutely.
even the dietitians are
You'll end
working
up doing
towards
it.
that.
Yes.
There is actually one question which is repeatedly posted. Can you suggest ways of measuring accurate cooked amounts by the
Correct.
patient at home if they don't have a weighing machine at home?
Right. So what we do is that even otherwise, we are not telling them to use a weighing machine. So in fact, on a 70 calorie exchange, because of its inherent structure, they are cooked weights that we are talking about. We see the bowl size. It may be the Indian steel vati. It
Yes.
may be the bowl. So we see that, and from that we are able to say, okay, this is your standard bowl. So maybe only once we know, we are able to assess now today as counselors that this looks like a 150. If you don't fill it to the top, this is giving us 150, giving me 200 grams or 150 grams. A glass roughly 3/4, a regular this glass would be about 250 ml. So when I say half a glass, I know it's 125 ml. So this is how we can come to the best accuracy. If ever we feel there's an odd piece or something that they're using, then when they visually, we tell them to put water and measure once. So we
Yes.
get at least the volume of what that is. A
Mhm.
basic method. It may not serve the grams, but they're interchangeable as when we really practice in absolute practice. So that's why then we are able to understand that you're talking about this size vati, this size bowl, this size glass, and they stick to that. So they also develop a pretty good estimate. We have not seen
Yes.
that going very wrong. And the chapati, we tell them to only weigh once, but we are able to visually make out also that this looks 30, this a fulka is 15. and a paratha will look double. It's the thickness also. So we're not making them weigh the dough, nothing. It's only the cooked once. If they can't do it, we can visually make out. So
Yes.
we help them and assist them and guide them on that.
Yeah. Actually, what you are saying is very right. And behind this, actually, your ability to counsel them and ability to give them suggestions, like how they can measure at home. The dietitians need to make a lot of effort behind the screen.
True.
Like you need to be aware of the whole varieties of foods, cooked foods and raw
Correct.
foods, and you have to prepare a database and keep it. Like in household measure, this is how it looks and this is how it would be,
Absolutely.
so that you are readily, you can give suggestions readily and you are well aware of that. And being well
Correct.
aware of the patient situation is very important for us.
Absolutely.
Very
Very
important
true,
for
ma'am.
us.
Very true.
There are some questions like, is sugar free more harmful apart from the other sweetness?
Okay.
That is one.
So no, so I would say that I would talk about it generically, more
Yeah.
generically. Let me
Yes.
compare because I don't want to go into brands. Is
Brands.
that the aspartame? If you're talking aspartame versus sucralose, there are basically two in the market. The third is stevia.
Mm.
Abroad, there is a combination of sulfame K with aspartame, which usually comes in the diet cola drinks,
Mm.
which we don't land up dealing with too much. But none of them are harmful over the other. Yes, I would say if you were to ask me, bottom line, sucralose is found to be safer in far more situations, because aspartame, if I were to expand and tell you with relevance to diabetics, especially young ones who are in growth phase, who are still developing, if it's a type 1, we are not giving aspartame because in the development phase of the brain also in youngsters, there is a lot of amino acid milieu which is balanced, which may be tipped. So we do not want them, and they tend to have high amounts because of their kind of food consumption
Like,
or beverage consumption. And if there is a PKU or a phenylalanemia, then we do not give the aspartame. So aspartame is not less safe, they can be used, but sucralose is found to be safer in these situations. But overall, we are not giving the artificial or any sweetener to mainly the artificial sweeteners or even stevia when a youngster is in the growth phase. We let the maturation be complete and then only we usually allow. Otherwise, we build in for greater adherence, we build in some of the sweets, etc. They are on insulin, we can adjust it as long as we're taking care of everything else.
so only thing is, you should not leave them free to decide on their own how much of sweet they
Those
can have
decisions
for
have to
their
be
taking.
yes, taken with the counselor, because it is parent, child and counselor if they are minors.
Yes, yes, yes. That's very important, because adults they misbehave like that sometimes because they consume insulin, because they are both the chronic diabetics. They are on
Yes, so
hypoglycemic
they
as
take
well
the
as
leeway on it, but they should not
ethically.
go overboard.
Yes,
Yes,
yes, yes. Sometimes they tend to do it. That
true.
leads us to the next question, because of diabetics. No, of course, everybody likes fruits,
Yes,
and fortunately or unfortunately, the liking is more towards sweet fruits and pulpy fruits,
right.
not the juicy fruits.
Yes.
So their argument is it does not contain glucose; it contains only fructose.
Okay, I'll elaborate on this. This is some of
Yes,
our,
please.
very, very favorite topics, and
Topic,
also very
yeah.
relevant for people, for counselors.
Yes.
Okay, I'll put it this way. If you go, I'm going by the 70 calorie exchange just to elucidate that the group 1 fruits are the less sugar containing. I'll talk about the sugar part also. The overall less sugar containing, so they can be had in suppose 100 grams as one serving. The type 2 are the ones which are sweeter, so they're eaten in half the quantity. The examples are elucidated in most books and you'll get the information. Important thing to understand is that yes, if you really read, you will see that even the fruits of different types have different proportion of fructose glucose. So you don't blanketly think it's only fructose one. There is glucose also in some, but bottom line is yes, if it's mainly fructose is independent of the particular enzyme to be metabolized in the body, so it works as a slow sugar. So there is a difference. The glucose will hit much faster. The fructose works and is metabolized independent through a different pathway in the metabolism of even of any human being. So it will work as a slow sugar. That's why when we say give the whole fruit, I'm not talking about fruit juice. When you give the whole fruit with the pectin, with the fiber, with everything, and then it is a fructose base, because it's fructose base, you will find that it will go into the body much slower and have multiple benefits. beside because of the fiber, etc. additionally. But the fructose, yes. But if you go, I have enough data on that also, and when we've seen the literature, that the fructose also you will allow will be only 20-30 grams a day. That means my serving per day, I'm allowing average, even a not a very uncontrolled diabetic, but even if they are getting to good control, we are allowing 2 fruits a day for sure, because that's the best way of getting the natural sugar which they crave for. And that is very beautifully to improve adherence. If you fit it in before the exercise or activity, they are very happy.
Yes, yes. And it has to be emphasized to them that ultimately it is possible for the body to convert fructose to glucose also.
Yes.
They
So
cannot
finally, the
go
sugar will
overboard.
get there. The calories have to be accounted for. It's just that the pathway is a little different.
Pathways are different. Yes. And for many people, understanding that biochemical aspect could be
It's
difficult.
tough. So we tell them that it's equitable
Yes.
to this. Like many people, patients who are very well controlled have tried and tested. They're okay eating a khajur also.
Yes, yes.
Dates, but I tell them replace your fruit with it if they're really well controlled and educated and have, are well informed. So we
Yes.
allow it, we give some of those liberties at times.
Yes. And then, as you mentioned, SMBG, so they can test themselves and see.
Exactly.
Maybe
So we
a
make,
day, one
yes,
day,
so
2 days, you can test.
yeah, we make them do that exercise.
Yes. Because they will learn it by self-experience. Their own experience also they will learn very well. That is true. And this kind of confusion is also there between jaggery and sugar. Okay, so there are many diabetics even today that um, jaggery is okay, but sugar is not okay for diabetics.
Direct sugar, ma'am, I would say that there is 10% of diabetics who actually don't do very badly on the direct sugar, but we don't want to make it a blanket statement when we are prescribing or counseling. So we usually say avoid direct sugar and refined products completely, because even your refined products are as bad as direct sugar.
And the jaggery, between jaggery and sugar.
Honey also people have
Honey,
questions.
exactly.
There
Honey
is no
also.
difference. It is
Yes,
finally
yes.
going to get there. It's going to
That's
get
what.
there. If not this way, it's going to get there the long route.
It's similar. It's the other name for sugar. So they're better name
Yes,
for all
they're
that.
getting
So how?
iron. But I have seen many diabetics. Once you handheld and you've understood, and we understood their pattern. They are stable. Sometimes very small leeways are made. We don't make it a practice.
Yeah, that is different. But actually, many people they strongly believe and they don't accept you saying that. No,
Jaggery and
jaggery is
honey also, and honey also.
honey also. Honey also.
That also needs to be with caution, that it's as bad as getting the direct sugar
Yes.
or shooting your sugars up. It will
Yes.
shoot your blood glucose.
Yeah. And that brings us to more towards the end of this session. So there are two factors which might influence the adherence of patients to the prescribed diet. I want you to throw light on that. Like, does the adherence or willingness to adhere to the counseling vary according to the age? That is one. And secondly, if the patient is continuously traveling,
Correct.
so how can we make it easy for them to adhere
Yes.
to that?
Yes. So
Two things I've just
yes.
put it
So
together.
a person, whether type 1 or type 2, they are dealt with a little differently where the traveling aspect is, because I would just say in a type 1, you're doing even more intensive counseling with the carb counting, the insulin dosages and everything. Now, when they're traveling, whether it's for work related, it's leisure, the point is that they need to understand their timings. So they understand time zone. If they're traveling within the country, they need to understand the time zone of the insulin.
Yeah.
If traveling out down the line as it will be, then there's likelihood that they will have to understand the change of timings and the time zone, which usually the insulin is adjusted if it's a type 1, and then the food is set. But overall in traveling, we always advise them to have carry foods. That's why I put the word carry foods, because they should be carrying with them, which is not not having to buy biscuits off the shelf, which is pure maida. So things which may be very difficult to on the route en route when they are traveling, is to have these carry foods with them. The SMBG or monitoring should always go with them. So even if they've tried some different cuisine outside, they're eating out, they learn there with the traveling, the eating out or a restaurant dining, or what type and how to order and what to order. So if you make it a blanket, no, it will not be acceptable to. So improve acceptability, you give them what are the better choices when they're eating an Indian cuisine or they're eating this. So depending on where they're going and how, when they inform us, we give them an overall view. that you stick to this. If your timings you cannot stick, it may be a little half an hour here, 1 hour here, then have a carry food with you if you're sure you're not reaching a destination or any food source. So depending on food ability, where they are traveling, how the medication is already set the regimen, and then we set it accordingly. We teach them and we train them to understand the foods and how to break up the foods in when they see any cuisine. So it's more a breakup to understand this is a cereal, this is a pulse, this has got a lot of fat, so how do I now make it a complete plan, and what do I select out of this, so they know how to order better from the menu.
Yes, yes.
That training has to be given.
Has to be given. Yes, yes. And the last point is on age. Does the adherence differ as per the age of the patient?
Okay.
Among type 2s and among type 1s also.
Okay, so I would say that let me tackle type 1 first. Type 1s are a slightly different story, because they also develop their complications at a much earlier age. The microvascular ones, they also land up in those difficulties far earlier than any type, almost, before the, like an onset age of type 2, you would say, so we need to deal with them very carefully. They do improve in adherence, they do comply, because they are young, they want to live life. So we give them that positivity, that we try to prevent as much of the microvascular, you keep good glycemic control, so we are trying to prevent. That gives them the motivation to adhere, because some of them may be also wanting to have children, go the family way. So there are a lot of factors, because it's their main productive and peak years of life.
Yes.
So their adherence, the motivation to adhere is far stronger and very strong. And we have found that, and then many of them are, that's why, ready to even go on an insulin pump and do the best that they can, even with that high level of expense. But even on a regular insulin dose, they're very well motivated. Now where type 2 is concerned, when sometimes there can be denial if they've got it at a much younger age than ever expected, which we know that it has moved a decade earlier almost over a period of years, their adherence is initially may be a little difficult, which is where we need to break that cycle and get that initial adherence to then achieve the long-term adherence. So there they may face a little more of a barrier in their acceptance. Then they adhere very well if you are going to give them the flexibility. As they age, some of them are so well learned, they know how to manage, they have self-learned, so there is a lot of self-management that they're doing. So unless there is some other factor which is very limiting for them in life, I think their adherence continues reasonably well even with age. Unless there is a limiting factor, that their mobility, they are lonely, there could be many other factors, then I think there's a complete deterioration. Then I think it's more psychosocial issue. But minute they are living their usual life, the adherence is good in that in-between phase once they have accepted. And then even with age, they continue, because they know I can prevent the complications. When you make them see the outcome of things, that's where our job lies, and make them see that the complications you can prevent, we can retard them, it can come at a much later age. They are motivated all the way through.
Thank you so much. Thank you so much, Sonal.
Pleasure,
it's wonderful discussing with you the various barriers and various factors. And it's very nice. As Veena said, it comes from your heart, because you are dealing with all these patients with a lot of passion and commitment. You really want to help them. That's the reason why your commitment speaks. So we are very happy to see a true dietitian and a scientist, of course, behind our dietitian.
Very kind of you, both of you.
And have you with us today on behalf of our chapter. Really, we are very happy. I invite Dr. Yadi now to formally propose. Thank you once again. We have already thanked you, but you deserve one more time of.
Thank you so much, ma'am.
Thank you, Dr. Subhadra, also for sharing this question answer session with me. And now since you are here, I think one person with diabetes has taken this opportunity to ask something. So I just want to ask that last thing is that what about your opinion about quinoa? It seems that person is mixing rice and quinoa in the for the meal. So should she continue, or what do you suggest? Since you are here, I think this question.
No problem. I'll be happy to answer. Quinoa is actually not a cereal. Essentially, if you see, yes, so it is fine to mix it. It is fine. It's almost like having a millet and rice mix. It's like a khichdi.
Okay,
so it's fine to mix it. There is no problem. It's the portion control only of the cooked portion.
Okay, Sonal, thank you so much. You have answered all the questions so well, and there's so many, compliments have come for you. Everybody found your session very helpful, informative, and some of them have asked for your phone number, some have asked for email, some majority want your slides, because they're so good. And what I liked, you have very in simple words, you have explained everything. Though you are scientist, you yourself, you have conducted so many researches, your papers have been published, but I think this your unique ability to able to converse in a very simple language, because some students are there, some patients are there, so you have satisfied all, and I'm sure they will all look forward to bring now adherence in life, and they are going to have a very satisfying life ahead, and because they have taken drawn a lot of inspiration from what you have said, and I'm sure later on they'll try to contact you also.
No problem, ma'am. We're happy to help.
And very nicely you are explaining, and I think being a biochemist at BSc level, I think for that explanation of metabolism and yet in a simple words, that was really impressive. So thank you once again on behalf of Mumbai chapter of Nutrition Society of India, and behalf of all the participants, and our YouTube recording is there, so people can view it later also. So we look forward having you again later also for some
anytime, ma'am. Anytime it will be more than a pleasure.
Yeah, that's so kind of you. And thank you very much. Please keep writing more books and chapters and for everyone. And thank you so much, and wishing you all the best. And now I would like to invite Dr. Neha Sanwalkar to give some final instructions to the participants and to conclude the session. So Dr. Neha, request you to come. Thank you so much.
Thank you so much, ma'am. Thank you, Sonal, for an excellent session. So just a second. I'd like to make an announcement first on our upcoming webinar, which is on 12th of December. So to introduce what the webinar is about, the circadian rhythms are physical, mental, and behavioral changes that follow a 24-hour cycle. Basically, the light, that is the sun, and the darkness, that is the moon, and the whole cycle, it affects us as living organisms, and this changes in the light and the dark, they affect how our organs work, and therefore it affects the amount of food that we eat, the amount of hormones that are released, our body temperature, the way that is, in short, it affects the entire metabolism. And that is why Nutrition Society of India, in association with Kellogg's Nutrition, is organizing an international webinar on "You Are When You Eat: Role of Chrononutrition in Metabolic Health." So chrononutrition is all about how the circadian rhythm affects our metabolism and nutrient intake. We have an international speaker, Dr. Jonathan Johnston, who would be giving a talk on this topic. The registration link for the webinar has been sent to all registered participants along with the Zoom link for today's webinar. We would also be sharing the registration links on our social media handles tomorrow morning. So if in case you've missed out, you can look in for that. The last instructions are, so if you want to get the certificates, it's compulsory that you fill the feedback form. The feedback form has been sent to you along with the Zoom link. The feedback form will be active from 7 p.m. today until 12 midnight tomorrow, and it will take us 7 to 10 days to send the certificate. So unless and until you've not got the certificate by 10th of December, only then you message us to ask about the certificates. Also, if you have not filled those feedback form by tomorrow evening, it would not be possible for us to send you the certificate. Also, before you write to us about the certificate, please check if you've got the certificate in your spam or promotion folders. So that's all the instructions that I have to share with everybody. Thank you so much, Sonal, once again. Everybody have a good evening. Thank you, everyone.
Thank you.
Thank you.